lecture, so it makes the transition easier. For those of you who don't know me, I'm Sophia. You probably know me from this whole year. But basically, I kind of was struggling with the topic if I should do a medical topic or a non-medical topic. And so instead of deciding to choose one or the other, I just had to do both. So basically, I'm going to talk about some medical myths and residency life lessons. A big thanks to Dr. Willis, Hassel, and D'Souza, and Dr. Gernsheimer. But essentially, this lecture is also called just me talking about a random stuff. We'll go with the word stuff. Basically, how this is going to work is I have just a potpourri of stuff. You guys choose and tell me which one you want to talk about, and we're just going to click and talk based on how much time we have. So these are your topics, your medical myths and residency lessons. Which one you guys want to talk about first? Six. Okay, talking to consultants, really, that was a popular one. Okay, all right.
You were going to cut.
That was what I was going to cut. All right, so residency life lesson 6. And all the pictures on here are trolls of conference or like something that we're doing with learning. This is when we try to take one of those tests to get certification, and we all just doing it together. I'm in the back distracting Stephanie, so she didn't notice all of it. All right, so just an overview of the scenarios when to consult, right? So this is kind of obvious, but just so we kind of go over it, you consult for a critical intervention, right? The kind of an example is, all right, you have a STEMI that needs reperfusion. You have endovascular therapy for stroke. Another one is a procedure request. You have a fracture that looks like it's going to need basically a surgical fixation. In-person eval management. This is if you have a question for a specialist, like they're on those new diabetes meds and having some side effects, and you want to talk to endocrine or hematology or things like that. Or if you're in a situation where you're in a community site and you basically need to have a remote eval management by specialists because they're not in-house, right? So these are the scenarios. Now, one of the studies kind of went through, this is 10 et al. It's from like the Journal of Emergency Medicine, went through the factors that create conflict with consultants. And you can see here, not knowing you or you having a bad reputation and vice versa, poor communication, disagreeing with the plan, providing inappropriate care, failing to collaborate, and external stressors. And external stressors are like, I have 5 consults, or it's 6:30, I'm about to sign out. And those are kind of those examples. The 2 factors that consistently showed up in this paper that led to positive interactions is trust and familiarity. Now, unfortunately, we're in residency, and all of these people, our consultants, are constantly being flipped over and changed over to the new resident, right? So unfortunately, this is kind of hard for a resident to gain during residency, but I kind of argue that when you're off service, right, especially the ongoing PGY2s, this is that opportunity to get to know your off-service peers so that you can get that trust from them. And then when you're 3 or 4 and you're consulting them, they already know you. But the things that, because we don't have this ability to do, it's kind of focusing on these former factors to avoid. So there are actual consultation models that have been published in the literature of like how you talk to a consultant. The one that has like the best data behind it is the Kessler study, the 5 C's. And they actually did this with medical students where they split them. Some did the 5 C's and talked to a consultant, and some didn't. And basically there was like increased satisfaction with the consultant using the 5C model. The big take home point here that I want to kind of bring up, and I had to learn personally, is what I bolded, the question. And this is kind of important for a few reasons, right? One, you need to ask a clinical question so it orients your consultant. So they exactly know what you're calling them or consulting them for. Hey, even if it's for admission, you say that. If it's for, hey, I'm concerned about a posterior cerebellar stroke, I think they probably need further imaging and a stroke workup, say that. I think this is a fracture that has a large degree of displacement that may need surgical intervention, say that, right? Because then it orients your consultant. But to take it a step further, it also forces you to know the actual management options, because you're not just saying, hey, I have a fracture in room 3B, can you come see it? You will then have to be forced to say, what is the criteria for surgical intervention? And that's the question you're asking them. And that actually puts some power to you, that you're not just like dumping the patient on the consultant, but you're saying, this is my question. I want to have a discussion based on this question. So this is kind of the key take home. And this is actually, in a lot of the papers, they talk about one of the biggest fallouts that people like forget to do when they basically consult somebody. So these are all very short, by the way, But this is the too long didn't read. Structure the way you talk to consultants and always ask a like clinically relevant question so you can orient them and yourself. Okay. All right. So that was that. What do you guys want to do next? Number three. BP cuff measures BP. Like, whoa, right? All right. So this is the medical myth that blood pressure cuff measures the blood pressure systolic and diastolic. So this is technically a myth. Most non-invasive blood pressure monitorings, like our automatic blood pressure monitoring, use something called an oscillometric technique. And this technique basically uses like amplitude waves and actually measures the max amplitude. And can anyone guess what that max amplitude is? It's your MAP. So actually these like automatic cuffs are like actually measuring your MAP, and then each company or manufacturer has an algorithm in place that then calculates your systolic and your diastolic pressure. So systolic and diastolic are actually computed. What's actually measured is your MAP with those automatic cuffs. So why is this even relevant, right? Because actually the MAP is a very important measurement. So there's been a lot of instances, right, where the nurse comes to you or the medical student, or you ask the junior or the junior comes to you, hey, the pressure's 110/70. It's 90/50. Like, what does that mean, right? And how is that relevant? A lot of times the question I then ask is, what's the MAP? And this is kind of where the conversation goes is, there's actually been literature that compares non-invasive blood pressure monitoring to intra-arterial blood pressure monitoring, like A-lines. And there's poor correlations when it comes to systolic and diastolic, especially at the ranges of low blood pressure and high blood pressure. But the MAPs actually stayed pretty consistent, even when the patient was on vasopressors. So, and actually there's a study in critical care medicine, which I'll show you the graph after, where they compared using non-invasive blood pressure versus invasive using MAP and systolic. And the systolic measurements, when they guided therapy based on systolics, there was an increase in AKIs below like a systolic of 70, versus when you use a MAP guided therapy, it was actually not statistically significant. And they actually found the same kind of results with ICU mortality. And this was from the Critical Care Medicine Journal. So basically, you should always use MAP as your preferred guided therapy for ICU treatment for like sepsis and hypotension. This is not a topic of like stroke where you're like have certain like measurements that you need to kind of monitor. That's kind of so this is a chart from that paper. The AKI group had 1,600 patients. As you can see here, this is when they're using systolic blood pressure as a marker. And when you get from as your guided therapy, right? So when the systolics were dropping below 80 and you're using your systolic to guide therapy, the AKI rates were higher than invasive. But when you're using MAP guided therapy, they actually pretty much kind of align the same. And then for ICU mortality, basically kind of the same thing. When you're using systolic pressure to guide therapy, the mortality increase, but when you're using MAP guided therapy, it's actually not statistically significant. But let's take this a step further, right? So there's this old kind of view of like non-invasive blood pressure monitoring and invasive blood pressure monitoring, right? That was kind of the split. But you kind of also have to think in your arterial tree, which kind of is an example here, your radial A lines are all the way over here. And how much accurate is that compared to your central branch, your central arterial branch, right? So there's actually been some studies that have compared non-invasive to radial and then radial to femoral. And basically the take home here is between radial to femoral, there's actually a margin of error, especially when the patient is very sick, like they're on ECMO or have really high vasopressor requirements, because basically at this point, these vessels are getting constricted now and not having as reliable measurement as central pressure. And that's what you're more worried about, right? Because that's how you perfuse your end organs. So the new model is radial lines and non-invasive are kind of the same, and then femoral and radial are where you kind of have that big jump. So this is kind of the recap here. Is non-invasive blood pressure is actually not that bad compared to like your peripheral A lines if you're using MAP guided therapy. But if you have a patient that's very sick, needs high vasopressor demand, then you may actually just want to consider putting a central A line catheter like a femoral catheter. So that was basically this medical myth. Any questions? No? All right, let's go to the next one. All right, what do you guys want to do next? One? Okay, all Definitely one? All right, so all right, UTI and altered mental status. The kind of intent for this was like basically throw this in neurology's face when I asked for a UA, but actually it kind of developed into a different learning point as I was going through the literature. So before we even get started, you gotta know some basic definitions. So ASB, which is asymptomatic bacteriuria, is when you have bacteria in the irrespective of pyuria, which is white blood cells in your urine, but you don't have any symptoms or signs to attribute to a UTI. UTI is you have some signs, symptoms, or systemic symptoms that may suggest a UTI. Now, there's a whole set of literature on like what are like the actual like likelihood ratios and pretest probability based on symptoms in your urine for UTI, which I'm not going to go into. But from one of the studies I was looking at, this is just the likelihood ratio of symptoms, and then adding nitrates and like moderate pyuria increased the likelihood ratio to like 4 and 7, based on nitrite only and nitrite and pyuria. So just so you guys have an idea, this is the difference, and this is why it's key to this myth, is that you get urines on patients who are asymptomatic for screening. It's technically ASB if it's positive. So there's a couple of issues here. First is the issue with the literature. Dr. G, I had to put this picture in. Most of the literature on this UTI causing delirium are all observational studies, case series, or retrospective studies. The issue is a lot of them are on elderly patients that have many other confounding factors that could attribute to delirium, and none of the studies except one actually like took that into account and split them up based on those confounding factors. So there's a lot of confounding factors in these studies that weren't taken into account when they were basically putting the population together. The other thing is a lot of these studies are doing chart review and going through ICD-9 or 10 codes now. But when you're doing that, people put in the diagnosis of the UTI without actually having like objective criteria, or it's actually ASB and they put in UTI, or confusion or delirium. And a lot of these studies did have preset like definitions that had an inclusion criteria for the patients. So that was just the issue with the literature. The issue with the patient population is a lot of elderly patients already have a high prevalence of bacteria in their urine. And actually like elderly people who live in long-term care facilities have even a higher rate of that. And there's actually some suggestion that having just colonization without symptoms actually may be protective. They did a study in young women who had bacteria like ASB, and they treated some of them and they didn't treat some. And the treatment group actually had symptomatic UTIs in that 1-year follow-ups to suggest that basically it's protective sometimes. And then delirium in itself is a disease process that's fluctuating, it's waxing, waning, and self-limiting. So sometimes that in itself may resolve and you're thinking it's actually the treatment, but it may not be. So the question next that I have is, a lot of people will say, and I'm sure this is on your minds, is, well, if they're altered, you can't ask them the symptoms, right? Like that's basically what the next thought process is. They can't tell you the symptoms, so you should just treat it. So how the literature has circumvented this is they actually did just treat delirious patients and to see if the delirium improved after treatment. And there's no good evidence on this either. So these are the reason I chose these studies is they're actually in the IDSA like 2019 guidelines. They were referred in those. But these are some studies that basically had like the first one, Hospital, split the 29 patients and half of them got Norflox for a week and half of them didn't get anything. There was no improvement in mean behavioral scores. And the last 2 studies basically also showed that there was no improvement of mental functional recovery. But then the next thing is, well, like how much harm is antibiotics going to do? So it does. So the last 2 studies actually show that there's higher rates and percentages of C. diff in the treatment group as well. So what do the guidelines say? So IDSA, this is the 2019, basically for patients who are confused or delirious without symptoms or systemic signs of infection. So like an unspecified fever is not included in this. It's recommended to assess for other causes and observe them before actually just empirically treating them with antibiotics. It's a strong obviously on low quality evidence. The SHIA, which is like the Society of Healthcare, the Epidemiology of America, basically doesn't even include delirium as a criteria to treat suspected UTI in non-catheterized patients. So the take home here is asymptomatic bacteriuria does not equal UTI, and asymptomatic bacteria does not cause delirium. All right, so that's that one. All right, any questions?
So are you going to treat your patients with acyclic bacteria with AMS then? Are you going to change your management?
I'm going to change my management, and it's going to be really hard because I think a lot of us knee jerk to do it. But yeah, I think it's reasonable, one, to try to find alternative reasons, and two, if they're not like critical, it's not unreasonable to observe them. And if you can't find another source or if something comes up that may lead to that, then treat them after the fact. If they're not like in critical condition. So
yeah. I think it's important because it avoids just the anchoring, right? Especially if you're potentially hitting these patients because they're altered as well. Once you set down that path, it's hard for everyone down this road to not unsee that too, until you realize 2-3 days later, oh, things aren't getting better. Now I have to go back
and find something else.
Also, biologically, it never made sense, right?
Yeah.
Cystitis is an infection outside the body. Your bladder is really outside of the body. If you have pyelonephritis, that's a different thing.
Right.
But if you have just cystitis or bacterial colonization of your bladder, it's outside your body. There's no reason that would cause an inflammatory response that would cause open mental status.
Yeah.
Obviously, unless you have like a fever, then obviously.
Yeah.
Right.
Yeah, which is what I want to highlight.
Yeah.
Like systemic symptoms are not included.
Right.
Yeah.
Right. If you have a fever, if you have a white count, if you have bandemia, and the urine is a possible source, then you should treat it.
Yes.
But asymptomatic makes no sense.
Yep.
And we should stop ordering it routinely on patients we admit.
Yeah, that's also part of the problem is ordering a test. What do you
Because
do?
what we do is we order urinalysis on lots of patients because the other services want them, and it just encourages bad behavior on their part.
I just think it's going to be a very hard knee-jerk reaction to stop people from
Agreed.
doing that.
Right, but we have to educate people.
Yeah.
Which is kind of why this is like important to go over it.
What?
Okay.
It's difficult. They give you a lot of pushback.
Yeah,
Well,
Yeah.
let them order it.
but now you know some of the literature. So
IDSA.
IDSA, right? Which you can't argue with. All right, what do you guys want
Next
to
we
do?
talk about the census problem.
All right, what do you guys want to talk about next? 7 LR. Okay. All right, I like this one actually because I like LR. Sinner, don't yell at me. All right. Lactated rigor increases serum potassium lactate. I've actually heard this before from someone as a concern. So I know it kind of sounds like a dumb topic, but it's something that sometimes is thought. So just for an overview, let's go through the content of IV fluid, right? So the potassium content, as you can see, like LR and plasmolite, I don't really know how to say this, has potassium versus normal saline not, and then LR has lactate. If you look at the pHs, normal saline is more acidotic than LR. And then just another myth to debunk, guys. Everyone keeps saying like LR is more expensive, but if you look at here, a can of Coke is $1.50, LR is $1.44, and normal saline is $1.26. Plasmolite's where you start to really get that increase in money, but it's actually not that much more expensive. And I have my own opinions about how I think LR is better than NS based on what I read, but I'm not going to go into that because I don't want to get yelled at. But there's some theoretical, there's a theoretical basis of how this is not true too. So first of all, if you're hyperkalemic, which means your potassium is going to be higher than 4, right? Because that's not hyperkalemia. And you're giving a solution that has less than your normal potassium. It doesn't add the potassium. It's going to shift that potassium. It's like when we give sodium, like our different solutions of sodium for hypernatremic because we're trying to dilute that sodium. I think Dr. Senior, what did you tell me about banana?
1 milliequivalent per inch.
1 milliequivalent per inch in a banana. So, I mean, people eat a lot of bananas. They're not running around getting hyperkalemic, right? All right, so that's the first problem. The second problem is your pH is actually a large influencer on your potassium, right? Like we all know this with our dialysis patients, our ESRD, we're given and basically all of that. So when normal saline, given that it's actually more acidotic and it causes a hyperchloremic acidosis, actually has a higher rate of shifting the potassium than a solution that's not acidotic or it causes a secondary acidosis. So the pH's influence is actually going to influence your potassium a lot more than just like supplementing some through your solution. So these are theoretical reasons for debunking this. The literature, so these 3 papers are actually all done on renal transplant patients. There's not papers for the ED specifically looking at the potassium changes, but there is some, like the salty D trial and stuff like that, do look at just like balanced crystalloid versus non-balanced crystalloid. But let's just think, like if we're using renal transplant patients and checking potassium, I think we're okay, like extrapolating this information to people who are not in renal failure. So all 3 of these studies basically intraoperatively gave LR or normal saline to these patient groups, so 51, 52, 74, and they basically were checking to see how much of the potassium shift in each group, and were they statistically significant or not, right? So in O'Malley's study, they checked to see what was the percentage of developing a potassium greater than 6, and it was 19% in NS versus 0 in LR, and it was statistically significant. Kajabi's study did a mean change, there was a positive mean change in potassium with normal saline and actually negative mean change in potassium with LR, which is statistically significant. And Modi showed that there was no statistically significant change in LR. 2 of these studies actually even mentioned that their patients that were on the NS group needed bicarb rescue therapy because they became acidotic after. So that in itself is like its own problem that you have to think about. So LR does not affect your potassium based on theoretical and based on the literature. So what about lactate? So this was a study recently published in the Journal of Emergency Medicine. They actually did a randomized control of a small group, 30 patients, but they did a 30 cc per kg bolus of LR versus NS, right? Because we look at the lactate for sepsis. So this is why they kind of did that thought process. And the increase in serum lactate was 0.93 in the LR group and 0.37 in the NS, but also non-statistically significant. And then the second point to make here is if you're looking at a 0.93 change in your lactate, you're doing something wrong. You really don't need to be looking at your lactate that intensely, right? At all. Okay, sure. Yeah. In 1997, the Journal of Medicine did kind of a similar study. They did LR versus NS and B5 water versus B5 LR, and they found no statistical significance. And they actually checked it like every 15 minutes. This is a graph from that, and there was no difference. So no, if anyone tells you this, please explain to them that this is not true and explain why. So too long didn't read, LR doesn't increase potassium or lactate. To me, LR also has shown now in new literature to decrease the rates of AKIs, and even in small doses. It's a salty D trial, if you want to look.
Sophia,
Yes.
so did you come across anything about that if people are in bad shock and their liver is not getting perfused, or if people have a bad liver, that using lactate is bad because it's not going to help anyway because they can't convert it?
I did, yeah. So basically, lactate gets metabolized by your liver. And there's no clear literature out there, but it's a relative contraindication, essentially. So it is something to think about. I didn't actually look into if there's like a lot of stuff out there, but I did kind of look into the contraindications of LR, and liver disease is one of them, just for that thought process. So that is something to think about. I just didn't look too deep into that subject. Okay, all right, next one. What do you guys want to do?
8.
Yes.
It's 8.
8. Oh.
No, 8.
I was like, oh, geez, that's how they're calling me. All right, residency list at 8. You know everything at the end of residency. All right, this was a big one for me because when you become chief or when you go to fellowship, there's some certain expectations. Oh, you know everything. Chief. No, I don't know everything. I'm not going to know everything, and that's okay. So basically, this is called the Dunning-Krueger effect. When I first looked at this chart, I was like, I thought that this was just your natural process of knowledge. That's how I had interpreted this chart initially. What this chart and the effect is actually trying to like point out is that there is this like ironical, basically there's some irony in the fact that the people who have lower knowledge bases actually have the highest level of confidence, even compared to the people of higher knowledge who don't. So this is more so an effect of saying, the less sometimes you know, the more you think you know, and that's basically a fallacy that you need to be like aware of. So there's actually literature on this in terms of the medical field, and this was a very interesting study. So they asked peers and physicians themselves to basically self-assess themselves in internal medicine, peds, and psych. And this is basically one of the charts of the results here. The actual is where the peers had ranked the physicians, okay? The physicians that ranked in the lowest quartile actually rated themselves, so this is perceived before, higher than the peers had rated themselves by 30 to 40%. But the more competent physicians actually had rated themselves less than what their peers had rated themselves. And actually this was more common in women than in men. Now, what they did in the study was actually show them what their peers had ranked them and ask them, can you rank yourself, assess yourself, right? And so after the physicians saw their peer assessment, they ranked themselves, and just look at the bottom third. They saw what their peers perceived them as and still ranked themselves a lot higher than their peers. Versus the physicians that were before actually kind of moved, perceived after, they actually moved up to be aligned with their peers' perspective. So the take home here is more so that if you feel like this inflated self-confidence or you actually fall into this trap of having lack of self-insight and also lack of being able to take feedback as well. So this is kind of actually shown in the literature to be proven. And basically the next thing here, which kind of goes with that, is it's okay to say, I don't know. This is kind of another life lesson. And the reason why you should be okay with it is, one, if you don't admit to yourself that you don't know something, then you won't be able to tell yourself what your knowledge gaps are. And you start your own learning, because then you won't ask questions when you don't say you don't know. When you don't say you don't know it yourself, you don't realize, oh, I don't know that, I should go look into that. So that's one thing. The other thing is, which we talked about, some self-reflection, is you kind of get an ego, right? Like, you don't want to admit you don't know. You want everyone to think you're smart. You think you're smart. You want people to tell you you're smart. And when someone tells you maybe you don't know something, you kind of like take it a little bit more harshly, which then allows you not to take feedback as well, and basically increases your reliance on other people, because you think like, I'm really smart. Why isn't everyone else telling me I'm really smart, right? Now, how do you circumvent this? Okay. One is self-insight. So we should always be reevaluating ourselves, knowing our knowledge gaps, and just being okay with it. Like, you don't have to know everything. And reframing, cognitive reframing, is just not seeing that as a bad thing. Like, it's not a big deal. You've seen patients that I haven't seen. I've seen patients you haven't seen. You might know something because you read something and I didn't, and that's okay. And that's what residency is for. And having a growth mindset versus a fixed mindset. So a fixed mindset are people who basically take opportunities to make sure they are like smart in that situation, and they kind of focus on things that they already know. Versus growth mindset is they use that as a challenge to help themselves become like more intelligent and increase their knowledge. And then the literature calls it grit. I know we all have mixed feelings about that term, but essentially the next thing to help you kind of avoid this is like being okay with it and taking on the next challenge that you don't know something, and being okay taking that challenge and facing those without having to, feel fearful or ashamed, and acknowledging that you're not going to immediately get rewarded based on that experience right now, but in the future as well. So that's what they actually call grit. So that's kind of a way to circumvent that. So the take home here is be humble. You won't know everything. It's okay to say, I don't know. And being insightful on yourself, because sometimes that actually causes some fallacies in terms of feedback as well. Any questions, comments? This one was a little like a little too much, but okay.
Well, I mean, this is a really important topic. I don't think you'll ever be a good physician, ever. You cannot be a good physician if you think you know everything. Yeah. You will miss things, you will not know things. There are things that I read about every single year or every 6 months because that's the only times I see it, and I don't remember it. I have to go look it up again. And I love it when a resident says, didn't that change? Didn't they have new evidence for this? And I'm like, yes, tell me more, because if I'm doing something wrong, I want to know it. That's why I like working with residents, because I'm constantly being questioned. Maybe not enough, right? And question you guys, I want to be questioned. And I think it's really important that you question yourself and question others, and don't be afraid to say, I don't know the answer to this, let me figure it out, because that'll only make you better. That's why I love this job, is because we get to read about things all the time and learn new things every single day.
Yeah, and not judging people for it is kind of a big thing too, which is important. Okay, what are you guys gonna do next? I think we only got room for like 2 more.
4.
Physician-patient relationships, okay.
Why not all of them?
Cause time.
Time is an abstract, it's all good.
Okay, this is doctor-patient relationships are complicated. It's not just I'm doctor, you're patient. There's a lot more to it, and each patient has their own dynamics. So this is actually something I learned while creating this presentation, is there's different patient models actually, and this patient model is not something you're rigid to. It changes from patient to patient. It mainly changes based on patient preference, but these are some things to be aware of. So the first one is paternalistic model. We kind of already know this, right? The doctor decides for you. This is what we're gonna do. This is what I think is best for you. The key here, though, is the patient is okay with that. They actually prefer this as their view. It's, hey, doc, I trust you. Do whatever you think is right kind of mentality, right? So this is a paternalistic model. This is actually now the trend away in medicine, given that like medicine is becoming more like a business, like a service kind of thing, where it should be kind of patient autonomy. But there are some patients whose this is their preference. You're the doc, you tell me what you want to do and what you think is best. That's paternalistic model. Informative model is kind of like I'm a robot. It's more so, all right, you're here for this, you're here for chest pain. Well, here is A option, B option, C option, D option. Choose, you decide. You don't bring in your own views. You don't gauge the patient to their views. You expect them to kind of just make that decision, and you go completely with whatever decision they make. This is not as popular because it like completely doesn't incorporate the relationship aspect of that patient and the doctor. It's more just like, here, you came for this service, here are your options, pick what you want. Deliberative, I like to call is like a maternalistic model, which is basically, all right, I've talked to the patient, I've actually tried to assess their views, their preferences, and I, as a doctor, based on my knowledge, is telling them their options, and I'm helping them come to one, but also telling them like, this is kind of what I think is best for you, based on what you're telling me your preferences are, and based on what I think is good for you. So it's more incorporated than a paternalistic, because you're actually taking into account their views. You're trying to find an option that's best for them, but you're still telling them what your preference is. And then interpretive is you find out what the patient's views are, their preferences. You tell them what your like options are, what your medical knowledge or advice is, but you are kind of gauging what their preference is and guiding them to their preference without telling them your preference. So this, honestly, I feel like I've had to do, except for informative, done most of these based on the patient's like discussion, their preferences, but it is something to know about, because when you're aware of it, you're able to kind of gauge how you're gonna kind of take that patient's interaction. Now, let's talk about lawsuits. That's a right? Oh, did it not switch? Oh. Okay, there. Yeah, you guys, I said that when you guys didn't even see the slides. That was good. This was a study, I know it's kind of old, but this was a study that actually looked through 67 depositions and kind of just like went through and talked to the patients about why they decided to sue, essentially. And what came up as the highest percentage was deserting the patient. The patient felt like the doctor wasn't there for them. That was the highest. The second was devaluing the patient's values. The third was delivering the information poorly. And the last was failing to understand the patient and family perspective. The interesting part of this paper was they then asked, like, did you know that there was going to be a bad outcome? It's called like maloccurrence. Like, did you know that there was already going to be about a bad outcome? And there was like a percentage that already knew that the outcome was going to be bad based on, you know, the discussion with the physician. But that actually wasn't the reason that they still decided to sue. It was because they felt like there was some sort of lapse in communication and that interaction with the physician. So that's one. The second part is, we always talk about like, you know, be nice to your patients, that helps with lawsuits, but like, what does that mean? Like, what do I need to do to avoid that? So this was actually a study where they had pregnant patients watch videos of doctors talking to pregnant patients and ask them, do you think this would have led to a suit? And do you think this physician is competent? And they did it based on positive and negative communication behaviors. So you can see here, right? Like we have waits at counties and downsides saying, hey, I'm sorry it took me so long. And not trying to seem so rushed when you're in the room. You know, when they tell you something that's sad or something, giving their condolences, not criticizing them for, you know, I haven't quit smoking, I didn't take my medicine today, or I haven't taken it, but asking them why, like trying to figure out why. Not pointing out any obstacles to the patient's adherence. You know, I didn't take my insulin because I had a patient yesterday who had a fire and it burned all his medications and he just hadn't had it in 2 weeks. Asking why. Not using too many medical terms, explaining the terms, encouraging questions, and not interrupting the patient. So these are kind of like just obvious examples of that. And then there's another study that also kind of showed the same thing in cancer patients as well. They want to know the bad information. If you don't tell them, they also are having decreasing dissatisfaction. And in this study, the physicians who got like higher negative communication scores were seen as less competent and actually had an increased rate of lawsuits. So it's also their competency was in question because of their communication. All right, so this is too long, didn't read. Be aware of patient-physician models and communication equals competency.
Yeah, I just want to add to that. That's very, very important. Patients really want that. They want you to explain things to them. And just one of my pet peeves are now, sometimes we give instructions from the computer and we print out 5, 6 pages of what your illness is. I'm not going to read that. And most patients are not going to read that. I think if you explain the important things to them, that's a lot more important, and patients prefer that. You tell them what, explain it to them. And then the other point that you make about at least not appearing to hurry. They did a nice study where in the emergency department, where they took patients who were in a stretcher. Half of the doctors who came to see them sat down, half of them stood up, like they're about to leave the room, right? They both groups had the same exact time that they stayed with the patient. When they asked the patients later, who spent the most time with you? They said the doctor who sat down at the bedside and seemed to be relaxed and focusing on them rather than standing up and ready to run out of the room. And they asked, what did they prefer? And they preferred, obviously, the doctor who sat down and did a lot of eye contact at their level.
Yeah, it's important. Okay, I think we're pretty much out of time. Sorry, guys, I'll send this out so you can see the next one. I just kind of wanted to go to system 1 and system 2 because I had to put a Kelly slide in here. When something doesn't make sense, ask more questions or do more tests. This is basically system 1, system 2 thinking. And there's actually studies that have shown this. This is a really interesting paper that kind of tried to prove this. And it helps you prevent biases. So I don't believe into EM controversies time. I'm gonna actually just scroll through the end here. Sorry, I usually don't do all this, but let's see. I just wanted to thank my family, my 2 best friends, that's Andy and Leon, and my family, my co-chiefs, my other residency family, all the juniors and seniors that I work with that's taught me so much, and my faculty, my APPs, Dr. Willis, basically helping me with conference all year. And I'll call you guys my big brothers. Let's do it. Let's go with that. Little and Kelly, and my co-resident. Okay, I think that's it. I'll send you guys my slides, and then we're done.
This was amazing.